Assalamualaikum and a very good morning, everyone. Thank you for joining us today to commemorate World AIDS Day, which is held annually on the 1st of December. This special forum hopes to showcase the incredible work and research being done by the team from the ID unit, Department of Medicine and Sharia University Malaya, with the aim to improving the lives of people living with HIV. I'm Dr. Sharifah Farida Said Omar, and I'm honored to be moderating breakfast at UMHealth today. We hope this forum will allow us to ignite dialogue, share knowledge, and inspire action in the fight against HIV/AIDS. This year's theme, Let Communities Lead, resonates deeply. To achieve equity in HIV prevention, treatment, and care, we must empower the very communities most impacted by the epidemic. Today, we'll delve into innovative approaches developed right here at approaches that hold immense promise for vulnerable communities, including men who have sex with men, MSM, and also women. We have three esteemed speakers lined up, each with a unique perspective to share. They will each present their work, and we will follow that at the end with a Q&A session. Please feel free to submit your questions in the Q&A box, or you can also ask live later. Now, before we start, let's have a look at this short video prepared by the wonderful ID nurse counselors of UMMC.
In your surrounding, like your friend, your family, or your colleague have HIV, what do you do? How do you support them?
I think, of course, and because we need to give them mental support first. We need to confirm them to let them know it's not actually bad thing. I know it's a bad issues, but then somehow need to guide them how to avoid, how to prevent from transmitting to others. I think that's
yeah. Very good. Thank you. Keluarga ataupun kawan-kawan yang terdekat ataupun saya lah, kalau saya mengalami HIV, adakah adik akan support? Pada saya lah, setiap manusia ni kehidupan tu sangat bernilai lah untuk setiap manusia. Jadi kalau kita ada sakit dan kita boleh rawat dia, saya sokong lah untuk dirawat lah. Betul? And if someone dalam family ataupun kawan-kawan ataupun siapa-siapa lah yang cik kenal ada HIV, bagi tahu dia yang dia ada HIV dekat encik, macam mana cik nak support dia?
Mentally support lah, basically. Just provide mentally support. Kalau it's ada financially support, financially juga lah, itu je yang mampu, I guess. Kalau nak buat, pernah okey lah. Berdoa banyak lah, cik.
Alright, terima kasih.
Okay, boleh saya tahu tentang perspektif anda tentang pesakit yang menghidap HIV?
So actually HIV, of course it's the disease for most of it's a more worrying disease for the public, but actually because I heard from patients before, they did ask me like if they are having HIV, can they pregnant, can they still carry out normal sexual activities? So actually for me, according to my knowledge, I did answer them. There's a quote in retroviral disease, it says new equals to new, undetectable equals to untransmissible. So I do actually encourage all the people out there that have HIV, don't fear to get treatment because the soon heal, the people is dead.
Let's communicate links.
Let's communicate links.
Hi, everyone here. Let's communicate links. Happy World AIDS Day.
Thank you very much for that wonderful video. It has definitely given us a glimpse of what the public and other healthcare workers think of HIV. Our nurses have indeed been a great support for our patients and for us, the ID doctors too. So moving on to the forum, many of you may recall that the initial driving force of the HIV epidemic in Malaysia was amongst people who inject drugs, followed by female sex workers, transgenders, and also men who have sex with men. However, in the past decade, sexual transmission has become the primary mode of transmission, and MSM are projected to become the main key population by 2030. Therefore, we need to shift gears and adopt new strategies to prevent sexual transmission of HIV and halt this epidemic, especially among the MSM population, just as how we successfully prevented and reduced transmission amongst people who inject drugs with the needle and exchange program. The same can be done for sexual transmission with new evidence-based strategies. With that, please join me in welcoming Dr. Sazali Basri, one of our clinical specialists at the ID unit. Dr. Sazali has been involved with HIV prevention research, and he will share crucial insights in his talk, A Step Towards Zero, Advancing HIV Pre-Exposure Prophylaxis in Malaysia.
Assalamualaikum and very good morning. Thank you, Prof. Sharifah, for introducing me. And my topic today will be about HIV pre-exposure prophylaxis. HIV was first reported in Malaysia in year 1986, just 3 years after the first case reported in the world. Since then, the case rapidly increased, mainly driven by people who injecting drugs. With the introduction of needle exchange program and also methadone replacement therapy, we managed to reduce the case by half, but yet the case still high in Malaysia. Recently, the Ministry of Health had informed us that on average, about 8 people had diagnosed HIV in Malaysia. And sadly, this affecting young people, more than 70 cases of new HIV in Malaysia involving young people aged 40 years and below. So how we can address or contain HIV epidemics in Malaysia? We had been practicing ABC, which is abstinent, be faithful, and condom for the past many years. Test and treat, in which we test the people at risk and also link them to care and prevention, in which we know when we treat them, U equal with U. Undetectable viral load will be untransmittable. We do partner notification and treatment, but despite whatever we have done, the case still steady, about 3,000 new cases HIV reported in Malaysia yearly. So we need to do some new intervention to address this issue. So that's why I think the focus of my talk will be D, which A, B, C, D, which is beside abstinent, be faithful, and condom, which is D, drug for prevention, in which pre-exposure prophylaxis. What is HIV pre-exposure prophylaxis? PrEP is the use of antiviral medication by people at high risk of getting HIV to reduce their risk of getting the infection. So there's 3 PrEP available, either oral PrEP, injectable PrEP 2 monthly, or a monthly vaginal ring. However, only oral HIV pre-exposure prophylaxis PrEP consists of tenofovir available in Malaysia. So PrEP is highly effective. Recent systematic review showed that the effectiveness of PrEP is about more than 60% if taken correctly, and nearly 100% if the patient's really compliance to taking PrEP. So what's the progress of PrEP in Malaysia? The landmark trial, iPrEP, was published in 2010, in which by taking daily PrEP, it able to reduce the risk of HIV acquisition by 44%. 2 years later, FDA US had approved the medication as HIV prevention, and later CDC had come up with clinical guideline for PrEP. In 2015, WHO had introduced the guideline of PrEP, and there's another landmark trial, which is IPERGAY trial, showed that you don't necessarily to take medications daily. You can take it on demand, and the effectiveness is about 86%. At the same year, our Ministry of Health had introduced PrEP in National Strategic Plan to end HIV/AIDS in 2015. Later, PrEP had been included in our HIV National Guideline, and in 2018, in second National Consultation on PrEP in Malaysia by Chair and MAC and also Ministry of Health, had recommended collaborative effort from public, private, and communities for PrEP. in UMMC, we had started PrEP services since 2015. Despite what we have done and also what the evidence had shown, the uptake is very slow. It's only about 37 clients had getting PrEP from UMMC from 2015 to 2019. So then next, a team of Cheerier had conducted a survey to see the willingness of high-risk key population on PrEP. And this study shown that moderate to low levels of willingness to use PrEP, and more works need to be done to increase PrEP awareness and also uptakes among key population in Malaysia. So what we have done, we proceed with my PrEP demonstration project. Basically, it's a observational open-label single-arm prospective pilot project among men who have sex with men in Kuala Lumpur, testing 3 differentiated delivery model in which public in UMMC, private at the Red Clinic, and also community-based organization or in CHCC Sentul. So this study had shown a very high retention rates, more than 92%, compared most of real world data is about 60%, and with with no HIV seroconversions reported for once during the 1 year follow-up. So as you can see here, Malaysia is reported only 130 patients using PrEP compared to our neighboring country is more than nearly for example, Thailand is more than 60 million people, 1,000 people taking PrEP, and also Vietnam also have a very successful module in delivering PrEP and reducing HIV in their countries. So we need to do something. So what we have done beyond demonstration project, what we realized that from this demonstration project, we not only demonstrate it, we also able to increase awareness and knowledge among key population on PrEP, and also it's creating demand on more people want to access for PrEP. So what I'm going to share today is the progress on 2 differentiated PrEP delivery services following my PrEP project. So we had further extended our service in 2 differentiated services at UMMC. I believe you guys are aware in UMMC, the PrEP service, as I said earlier, had started since 2015, and now we haven't extended our service with dedicated PrEP clinic, which is our ID daycare. The cost of PrEP in UMMC is about 35 ringgit per bottles. So there's also another differentiated service, which is community-based organization service at CHCC, which is one of the largest anonymous HIV testing and counseling center run by the community in Malaysia. This service is based on social intervention of sexual health, in which the clients need to pay, but of course the cost will be slightly cheaper compared to other private practices. So in CHCC, with the success of my PrEP, the clinic had become a full STI clinic since September 2018, and at this center the delivery is slightly different, in which it starts shifting to trained community workers with a doctor overseeing the service, in which the PrEP starting, the counselings, discussions is done by the trained community workers, and the cost is about 70 to 90 ringgit per bottle. So basically we adapted the service is through Princess Project in our neighboring country, Thailand, in which the key populations lay provider assessing the risk and provide PrEP counseling, perform HIV testing and taking bloods, then dispense PrEP with doctors consultation, which then the subsequent follow-up will lead by the key population themselves. So what's the progress? So as you can see here, initially in early 2019, there's rapid increasing in PrEP uptakes at UMMC and CHCC. However, COVID-19 slightly plateaued the uptake, right? and then it's slightly with the recovery, the uptake is slowly increasing again. So in total, for the past 2 years, nearly 900 clients had getting PrEP in UMMC and CHCC with median age of 31 years old, with 90% of them were MSM. So and of course we know the effectiveness of PrEP from the 860 client taking PrEP. Only one case of HIV seroconversions reported, but the client actually not taking PrEP. He had stopped PrEP around 6 months during the MCO, and then came again after that, planning to restart PrEP, but tested positive again. So then the link to treatment. And with just standard first-line therapy, this patient had achieved suppressed viral loads. So moving forwards, what we have done, just basically through what's our finding, we had managed a lot to convince a lot of the stakeholders to expand the PrEP in Malaysia. So as you guys know, PrEP had been given free in 23 klinik kesihatan in Malaysia for the time being through PrEP government 2023, and plan to be extended more in futures, right? For private general practitioner, there's an online HIV Connect in which they can learn about PrEP, how to dispense PrEP, and then can do attachment in STI clinic, including UMMC, so that they can more confident to prescribe PrEP. So there's also a new study conducted by my colleague from Ceria. So it's a pharmacist-led PrEP delivery service in which the community pharmacists will do the HIV testing, counseling, and dispensing PrEP through the service. We also have digital health or mHealth, in which we're using digital to increase PrEP, to increase testing and PrEP uptakes among the key population. For example, Jom PrEP and also My Heroes for MSM, and also Project Knock for transgender. This is conducted by Ceria team. And of course, we have My PrEP Locator, which is by Ceria to connect all the PrEP delivery service in Malaysia, so clients can just go to this My PrEP Locator and find where's the nearest PrEP delivery in their places. And there's also Jom Test service in which self-HIV testing, then they can link themselves to either treatment or prevention. So of course, it's a collaborative with a lot of stakeholders, including Ceria, UMMC, Malaysian Aid Councils, and Ministry of Health. So what I want to say here is PrEP is very effective. If you taken correctly, the effectiveness is nearly 100%. So PrEP is not only effective at individual level, but also at populations level. As you can see here, with rapid enrollment of PrEP, it able to reduce the new HIV cases by 25% in New South Wales, Australia, 35% in England, and 50% in San Francisco. Even recently, Amsterdam only reported 9 new cases of HIV in 2022 due to made PrEP accessible and effective community response, which is in line with our World at this team this year. So they can just have 9 new cases in 1 year, but we every day with 8 to 9 new cases. So a lot of things still need to be done, and we hope by rapid enrollment of PrEP in Malaysia, we're also able to do the same. So as a conclusion, prevention is better than cure, especially when there's something no cure. So PrEP is effective. We better to prevent them from getting HIV, since HIV there's no cure, but even there's no cure nowadays, people living with HIV can live as normal people and can be controls, the disease can be controlled. So that's on from me. Happy World Aids Day. Thank you.
Thank you, Cecily. Can you just leave your slide there for a bit? I'd just like to highlight and thank UMMC for letting us light up Plaza red for this past 1 week. So some of you may have noticed it, but yeah, thank you so much for UMMC for allowing us to do that. Okay, so thank you, Dr. Sazali, for that wonderful insight on HIV prevention using PrEP, and also highlighting the importance of incorporating differentiated delivery services and also involving community-based organization to make it a success. The involvement of the community to deliver services to key population is paramount to make any new innovation to curb the transmission of HIV successful. That's the theme for this year's celebration, Let Communities Lead. So our next speaker is Associate Professor Dr. Rina Rajasurya, who has an extensive research portfolio in HIV, aging, immunology, and amongst other things. She focuses on the long-term effects of HIV on our patients. With the introduction of the revolutionary antiretroviral therapy, ART, our patients now live longer. Dr. Rina's expertise will challenge us to broaden our understanding of what constitutes success in HIV management, extending beyond viral load suppression, and what constitutes extending beyond viral load suppression to ensure holistic well-being for our patients. We strive to give our patients not only longer lives, but also better quality of life. Her talk is titled Beyond Viral Suppression, Redefining Therapeutic Success in HIV Care. Rina, I give the floor to you.
Thank you, Sharifa. Can you hear me and can you see my slides? Can you hear me?
Yes, Rina.
Okay, all right. So thanks, Sharifa. So from the HIV prevention work with which Sazali has spoke to you on, I'd like to change gears a little bit and share with you some of the recent challenges that we've been facing in managing people living with HIV who have been living with the virus over many, many years, and some of the efforts that we've been doing in UMMC to address this issue. So the title of my talk is Beyond Viral Suppression, Redefining Therapeutic Success in HIV Care. This is the outline of my talk, and I'll start first by sharing with you the changing face of HIV disease in the era of antiretroviral therapy. I will then highlight some of the current challenges that we are facing to provide optimal care for people living with HIV, and share some findings from studies that we've done in UMMC, highlighting why we need a broader health systems response, and one which includes comprehensive chronic disease management as well as management of geriatric syndromes. And finally, I will very briefly touch on some of our ongoing efforts to build new models of integrated HIV care in our clinic in UMMC, leveraging on implementation research. And Anjana will talk to you more about that, demonstrating the work that she has been doing in women. So I might be a bit biased in saying this, but I think the management of HIV has perhaps been one of the greatest success stories in medicine. In just over 40 years, we have managed to change the face of this disease from one which used to be a death sentence to now a manageable chronic disease with even a prospect for cure. Life expectancy for individuals living with HIV has also been steadily improving over the years. And in this study done in the North American collaborative cohort of over 200 HIV treatment sites, we see that a 20-year-old who is an adult, a 20-year-old adult with HIV taking antiretroviral therapy is expected to live into the early 70s. And this is a vast difference from what it was in the turn of the century in the early 2000s. And this success is largely attributed to changes in policies where we now start treatment immediately, regardless of CD4 count in all of our patients who are diagnosed positive, as well as the improvement in more effective and less toxic antiretroviral regimens that we have today. And there have been multiple graphs, survival graphs such as this, which have from other settings, which have essentially shown that people living with HIV now have a life expectancy which approximates that of the general population if they take their treatment. So with increasing life expectancy, we also see a change in demographics, and we're seeing a greater number of individuals growing older with HIV. Now, in developed countries like the Netherlands, 2 in 3 individuals are expected to be over the age of 50 by 2025. And in the Asia Pacific region, about 30% or 1 in 3 individuals are expected to be over 50 years in the next 2 years. What does this look like in UMMC? When we analyze the age distribution of all of our attendees in our ID clinic between January to November of 2023, we see that about 35% of them are over the age of 50. And in the next 5 years, we can expect these numbers to grow to about 50%. So why is this a concern for HIV programs? As the population of older people with HIV increases, the nature of morbidity and clinical issues that they experience also changes. And in this study done in the Netherlands, now published almost 10 years ago, comparing the frequency of people living with HIV on treatment, the frequency of non-communicable diseases in people living with HIV on treatment to uninfected controls of the same age or age-matched, we see that the burden of chronic comorbidities in people with HIV is significantly higher compared to controls, and also occurring almost 5 to 10 years earlier in the HIV-positive group. This is now a landmark study which has essentially one of the first to demonstrate that people with HIV, despite taking or despite having really good control of their HIV disease, they are still vulnerable and experience an increased phenotype of premature aging. So in 2014, we established the Malaysian HIV and Aging cohort in UMMC in collaboration with the MALOB study program led by Prof. Sharul. The study recruited individuals who were part of our routine HIV care, who were coming back to our clinic as part of routine care. And the inclusion criteria is stated on the slides. And we also had a group of uninfected controls from community dwelling individuals. We successfully recruited about 329 participants with HIV and 290 participants without HIV, and about 172 pairs who were matched for age, sex, and ethnicity. Now, in this study, participants were assessed for a range of conditions and a range of parameters, including the presence of chronic comorbidities. And the median age in the match group was about 42 years, with all of them with well-controlled HIV disease. And you can see in this assessment that with the exception of liver disease and hypertension, all of the other chronic diseases assessed were higher in people living with HIV compared to controls. We also assess the presence of geriatric conditions in this cohort, and we see that the frequency of these conditions were higher in people with HIV compared to uninfected controls. And when we assess this as a burden, which we defined as the number of conditions co-occurring in an individual, we see that the burden is significantly higher in people with HIV across all age groups compared to controls, even after adjusting for traditional factors like education, employment, smoking, and alcohol consumption. When we assessed how the burden of these conditions were associated with health outcomes, we found that quality of life scores declined significantly, both in people living with HIV and controls, as shown in the graph here. But it's quite obvious that the decline in participants with HIV were greater compared to controls. And on average, participants with HIV experienced quality of life scores which were 2 times lower compared to controls, with an increasing burden of geriatric conditions. Similarly, increases in healthcare utilization was 5 times higher in participants with HIV compared to controls. And mortality risks measured through the VAX index or with VAX index was 4 times higher in participants with HIV compared to controls. So these data collectively showed us that although antiretroviral therapy has increased lifespan in people living with HIV, unfortunately, this has not translated to an increase in health span. And the increased life years gained from treatment is associated with increased chronic comorbidities, disabilities, and premature aging in people living with HIV. So, as healthcare practitioners, where do we go from here? HIV treatment programs have typically defined successful HIV care as achieving long-term virological suppression. And this is the main focus of most of our engagement with patients in clinic, as demonstrated here in participants from our HIV and aging cohort who were recruited 2 years after their entry into the cohort. We see that over 96% of them maintain good virological suppression and were highly engaged in their HIV care. But is this focus alone enough, given that most of our patients are growing older and at risk of multiple comorbidities? There is now growing acknowledgement both among HIV providers as well as the community that we really need a broader health system response, and monitoring of viral loads and CD4 counts are no longer enough. So in UMC, with 35% of our clinic patients over the age of 50, we are already starting to grapple with increasing complexities in care, which currently we're addressing with multidisciplinary team meetings with input from other specialities, from our pharmacists as well as our social worker. But as the demographics of older people with HIV increases in the next 5 years, this will be 50%. This will not be enough, and we will need to rethink our models of HIV care that we employ in our clinic. So while this might be different in different settings and dependent on resources that we have in UMC, at least we have been exploring approaches of integrating services as part of routine HIV care. And the first of these efforts is the launch of our ID Wellness Clinic, which will commence in the middle of this month. And it aims to provide preventative screening and same-day counseling for our patients. As part of these efforts too, we have 4 UMMC staff who are undergoing training in implementation science through a capacity building program called Chimera. And this is led by Columbia University and Treat Asia, which is a regional treatment network, on how to design and implement evidence-based interventions into HIV care. Each of them are focused on a different area, ranging from mental health, substance use, cognitive health, and women's health. And all of them aim to eventually integrate these services as part of routine services in UMC. I will hand over now to Anjana, who will tell you a little bit more about her work in integrating holistic services for women living with HIV in UMC. Before that, I'd just like to acknowledge my team in UMC, as well as our collaborators, especially from geriatrics and psychiatry, who've been extremely supportive in our efforts of building integrated care models. And I would also like to acknowledge our funders. Thank you.
Thank you, Rina, for the enlightening talk. I think it's quite clear that achieving undetectable viral load is just one piece of the puzzle in the HIV care cascade. As our patients grow older, we now have to look at the method of aging with HIV, which has its own challenges. The fourth 95% of the care cascade highlights the importance of giving our patients a good quality of life as they grow older. So finally, we'll hear from Dr. Anjana, another passionate young ID lecturer with the ID unit, dedicated to improving the lives of women living with HIV. Women are often overlooked, as men have always been most affected with HIV from the beginning of the epidemic. Dr. Anjana's work addresses specific issues faced by women with HIV, including the increased risk of cervical cancer and issues related to pregnancy. She hopes to empower women not just by addressing their physical health, but also the social, emotional, economic barriers they face. So her talk will be on the WOW Plus project, addressing holistic needs in women living with HIV. Anjana, I give it to you.
Thank you, Prof, for the gracious introduction. And a very good morning to all our esteemed colleagues and a happy World AIDS Day to everyone. I'm truly grateful for the opportunity to present the WOW Plus project, an initiative dedicated to the wellness of women living with HIV, aiming to address holistic health in this community. Here's the outline of my talk. I will begin by answering the key question, why women? Highlighting health considerations specific to women in the context of HIV. Then we'll take an in-depth look at the WOW Plus project and its initiatives. And finally, I'd like to share with you some of the work that has been done in UMMC, mainly in cervical cancer screening and mental health. So why women? For starters, a staggering 20 million women living with HIV. There are over 20 million women living with HIV globally, with over 40% of them in the Asia-Pacific region. In Malaysia, the 2022 Global AIDS Monitoring Report, which reflected data from 2021, reported over 67,000 cases from surveillance, but the estimates reveal a larger reality of close to 80,000 individuals. Now, although specific gender breakdowns aren't detailed in this report, historical ratios from 2020, when extrapolated, suggest that over 37,000 of these cases are actually women. And as the transmission patterns shift, which you've heard from Sazali and also Prof. Sharifah earlier, we mustn't overlook the persistent risk for women, including those in key populations, as well as the women living and aging with HIV. Women also face unique challenges based on the timing of their diagnosis, whether it was during a vulnerable stage like pregnancy or a transformative phase like menopause and aging. Single mothers in this group manage added responsibilities, often compounded by caregiver stress and histories of abuse. Additionally, women grapple with higher internalized stigma. There are also substantial barriers to care, such as this patriarchal Asian setting, which can affect healthcare access. HIV practitioners or their ID physicians or their FMS physicians are often the sole healthcare contact for these women. And specialized health services and HIV care generally run independently from HIV clinics. So all these insights, coupled with our experiences in clinic, prompted us to initiate the WOW Plus project. The WOW Plus project is an acronym for the Wellness of Women Living with HIV project. This initiative primarily aims to pioneer a women's wellness clinic at the University Malaya Medical Center, the first in the country, dedicated to delivering holistic services for women living with HIV across all socioeconomic backgrounds during their HIV follow-up. But how do we make this vision of having an integrated clinic for women a reality? It starts with our commitment to various research initiatives, including implementation science studies. Leveraging on the expertise and resources that are available at this university, we aim to generate valuable insights and evidence to support the establishment of a women's wellness clinic. Moreover, we hope that the WOW Plus project will serve as a collaborative platform, fostering research partnerships and knowledge exchange, not only within our country, but also throughout the region. So what aspects of women's health are we referring to? Guided by our national flower, the Bunga Raya, and inspired by the strength and resilience of women living with HIV at its core, each petal symbolizes a crucial facet of women's well-being: cancer screening, mental health, social support services, gynecological health, and metabolic health. Our initial focus has been on cervical cancer screening and prevention and mental health. We've started a little bit on metabolic health, namely bone and cardiovascular. And recently, through the efforts of my colleague Pui Lee, we've started a peer support group which included women as well. And today, I'm thrilled to share with you some of the work accomplished so far in cervical cancer and mental health. I'll first share work done in cervical cancer, which was our very first initiative. So in Malaysia, cervical cancer is a leading cause of cancer amongst women, and it's mainly caused by high-risk human papillomavirus infections. Now, women who have HIV are 6 times more likely to develop cancer, and this is mainly due to the delayed clearance of the HPV virus from their bodies because of their immune status. But the pathogenesis of HPV virus is such that once you get infected with it, it takes years to develop cancer, and thus early screening with HPV DNA testing can aid in early diagnosis of the infection, linkage to care, and subsequently prevention of cancer. And in Malaysia, there's currently no data on women living with HIV with regards to the prevalence of HPV infections and also cervical cancer rates. In UMMC, we have very well-established gynae-oncological services, HPV testing, and even a fully equipped colposcopy unit. However, all of this is run independently from the UMMC ID clinic. So prior to our intervention, in order to screen a woman for cervical cancer, let me take you through her patient journey. She'd have to be referred to gynae from the ID clinic, which means she has to walk to another menara, get an appointment that would be set for a different day, wait for the appointment on that day, come on the clinic appointment day, make a new pay for new clinic registration, and finally get her HPV testing done. So due to these logistical issues and the cost and the time it would involve, it truly deters patients from getting themselves screened. And so our aim was just to bring this HPV test into our ID clinic and then develop an efficient linkage to care and treatment pathway should our patients need or warrant more investigation. So in order to do that, we did an implementation science project. We first established the gaps in cervical cancer screening in our clinic in a retrospective chart review, and we found that at the time, only 12, which represented less than 10% of our clinic population, ever had HPV testing. So once we identified that clearly there was a gap in screening, we instituted structural improvements within the ID clinic. We ensured the availability of swabs, we oriented our nurses and doctors as to how to order the tests, and we also conducted a knowledge, attitude, and practice questionnaire with both healthcare providers and patients and provided educational pamphlets. And then we measured two outcomes: screening engagement, the one in light blue, and uptake. So what do I mean by this? So engagement was defined as any discussion on cervical cancer screening between the healthcare provider and the patient, and uptake just means the actual number of HPV tests done. So our first evaluation was at 6 months after the swabs were introduced into the clinic and we tried to teach everyone. And you can see that there was some engagement, but nonetheless very little, and translated to very little uptake. We evaluated the reasons why, and we found that doctors cited that they forgot to bring it up as an excuse. So we added a very simple intervention, which was just sticker reminders on patient cards when they came for clinic. And you can see just 2 months after that, engagement and uptake both improved significantly, although there was still a disparity between the two. This time, the response cited was that financial issues, the test cost about 160 ringgit. And so what we did was we formed a collaboration with Rose Foundation to obtain subsidized HPV tests for the B40 group, and we implemented a staff on site who was present during the ID clinic hours as a point of a reference for the clinicians as well as the nurses. And once again, we evaluated this, and you can see engagement improved significantly with someone there. Uptake, however, remained pretty similar. But at this juncture, though, from January to December, so 1 year in 2022, the uptake of HPV testing had already increased by threefold in that 1 year compared to before. And so we decided to just leave everything as it were and just continue uptake for monitoring uptake for 2023 without adding any further interventions. And you can see that from January until now, the uptake remains at quite a steady number. And this is actually quite reassuring because despite no added measures, our team is still continuing to get our women tested for HPV when they come to ID clinic follow-up. And in fact, when we look at the actual numbers of women who have been screened, they are eligible 151. So this is based on age and the fact that they haven't had a hysterectomy and things like that. We've actually screened 57, representing over 1/3 of our women in the clinic who have been tested compared to less than 10% before. Thankfully, the majority were negative, as you can see. This is 50 patients who didn't have to go through that patient journey and got it done in their ID clinic. But unfortunately, 7 women were positive, representing 12% of the population, our population. The figure 12% here is actually a number that seems lower compared to what is published for HPV rates in women living with HIV. But I believe the limitation here is just that our sample size is really small, and we are working towards expanding our scope. Of the 7 women who had a positive HPV test, 4 were successfully linked to colposcopy. None of them had malignant lesions, and thankfully now these 4 women have had interventions in place to prevent them from getting cancer. One woman opted to go to a private OBGYN, and one has defaulted, and we're trying to re-engage her back in care. And unfortunately, the 7th person, she sadly passed away due to other advanced HIV-related complications. Nonetheless, this project has enabled HPV self-testing to be successfully integrated into the ID clinic. And it's really important now that we continue to work hard to ensure sustainability. The initiation of our wellness clinic that Rina mentioned earlier will allow for our ID nurses as well to help to monitor when the next HPV test is due. And extremely good support from the gynecology team was instrumental in making this a success. Moving on to mental health and women living with HIV. As Prof. Rina mentioned earlier, I'm grateful to be a Chimera Fellow, which is teaching me implementation science. And one of my projects with them is with mental health. There is evidence, although very limited, that women experience higher rates of depression and anxiety when compared to their male counterparts. And just like most services, mental health services in UMMC are also run independently. But before jumping the gun and working towards integrated services, we felt it was really important to understand what our patients really wanted. And so this is actually a mixed method study with a qualitative component, and the qualitative aspect consists of in-depth interviews with patients and focus group discussions with healthcare providers. This study is very much still a work in progress. I've completed just over half of the planned interviews and analyzed 8. I just thought that I'd share 3 key points of what we found so far. We found that women were willing to have their mental health screened if it was done in the ID clinic, and they preferred a face-to-face or in-person screening rather than something done digitally. Additionally, we found that our patients did not like to talk about the past, and this avoidance of past reminders was a rather recurring theme in many of the interviews. As shown here, a patient said, "Kadang-kadang tak suka tanya banyak soalan, sebab buat saya sedih. Tanya macam mana you kena ni penyakit, saya feel bad." And another patient echoed the same sentiments. This highlights the importance of structuring our screening and approach in such a way that doesn't resurface bad memories for them. And the third important thing we found was the timing of support. And the timing at the point of diagnosis was actually crucial. And one patient powerfully asked, "I think to myself how I went through so much in my life. Where was all this psychiatry during my era, you know? Why was I never referred to one? Was it because my parents didn't think about it? Was it because my doctors didn't think about it? You know, why I didn't speak to anyone about it?" And then I was thinking, never mind, it's okay. What's done is done. I just tried to console myself and say, you know what, you're strong, you've been through a lot, you've done everything, you can do everything in life. You know, that kind of attitude. Each of these voices offer a profound insight into the unique challenges and perspectives of women, emphasizing the need for tailored approaches in care. I'm still learning so much from every interview done, but understanding what patients want and need is crucial. It's also important to get the points of view of all stakeholders, and so having focus group discussions with the relevant healthcare providers has also been carried out. Moving forward, though, is that the wellness clinic that Prof. Rina mentioned is a step forward to be a platform to integrate mental health screening into the ID clinic. Aside from cervical cancer and mental health, we've also started and done some very little work on bone health and cardiovascular health. So please feel free to scan the QR code that will link you to our WOW Plus website, and everything that we have done so far, including teaching materials and everything, is available for download. Moving forward, we remain steadfast in our pursuit of establishing a multidisciplinary clinic for women living with HIV. However, to achieve comprehensive care, additional research in various facets of women's health is imperative. We need to quantify the burdens, identify specific needs, and facilitate collaboration among diverse disciplines. If you are engaged in clinical care or perceive aspects that might benefit women living with HIV in your area of work, please do connect with me. We aim to address all dimensions of care, and you can reach me via my email, anjana@ummc.edu.my. Before I end, I'd like to acknowledge all my mentors, my very supportive ID work family, from the clinicians to the psychologists to our amazing nurse counselors, also my research mentors and the team at Chimera, Treat Asia, and Colombia. I'll also be nowhere without my RA, and to all the various funders and collaborators from the different departments and Faculty of Medicine that have been immensely approachable and supportive. But most importantly, to my patients, the women who brave and face the world living with HIV every day. Thank you and happy World AIDS Day.
Thank you, Anjana, for that wonderful talk. I feel your work illustrates our continuing effort to provide better services for our patients generally and for women with HIV specifically by scrutinizing the current workflow and identifying the barriers to linkage to care. So we have about 10 minutes left. So I'll open the floor for questions. We have a few questions in the chat box. One has been answered by Dr. Sazali. I think the next one from Prof. YK Chan. I think I'll get Sazali to answer this if it's possible. How does the prevention drug ward off the infection? Can it be used for needle stick injury patients? And please share the side effects of the medication.
Thank you, Prof. YK Chan, for the question. So basically, HIV pre-exposure prophylaxis using two types of antiretrovirals, in which blocking the virus from entering the cells and to preventing the infection. So for needle stick injury or even red case, we're giving post-exposure prophylaxis, in which we are giving 3 types of antiretroviral. So yes, similar ways can be done for needle stick injury and also even red case for such cases. In terms of the side effects, it's very safe. Usually they just have, like other medication, they just have mild gastrointestinal side effect. Now they are vomiting, bloated when they start the medications, and it's resolved after 1 to 2 weeks of taking the medication. There's some concern about kidney safety, but most of them actually associated with other things, for example, diabetes, high blood pressures, and other kidney-related comorbidities. So it's very safe, it's cheap, and it's cost-effective.
Thank you. The next question, again from Prof. YK Chan. What percentage of patients inherit the HIV from their spouse in spite of advice given for protective sex? Can they come to for preventive HIV infection if they suspect they have become infected as a result of barrier breach? I think I'll just chip in a bit here. I can't remember top of my head the percentage of patients who gets it from their spouse despite protective sex, but I think when we talk about prevention, the traditional ones that we always talk about is protective sex using condoms and so on. But now we move on to using medication and PrEP using tenofovir and tricitabine in this country is the drug of choice or the option that we have. And it's, even though Sazali highlighted using PrEP in MSM, but it's actually can be used by any what we call serodiscordant couples, where one person is positive while the couple or the partner is negative, be it a woman or a man. So the negative person can take PrEP to give that additional protection to them from getting HIV. But at the end of the day, if you're in a stable relationship with a serodiscordant couple, point number one is for that positive person to be undetectable, because U equals U. So when the positive partner is undetectable, that itself protects from any transmission to the negative partner. So giving PrEP to a negative partner in a serodiscordant relationship gives that additional protection for that negative person. If they do not take PrEP and they just use protective sex using barrier methods, then of course there is post-exposure prophylaxis that they can take to give that additional protection in case they have been infected with HIV. So I hope that answers your question, Prof. Chan. Let's see if we have any other questions. Okay, I think there was a bit of a problem. There might be a bit of interruption in the transmission. So this whole session forum has been recorded and will be uploaded later on. Okay. Okay, thank you, Prof. Chan. Okay, do we have any other questions that maybe someone would like to ask live? I think there is an option to ask live, right? Okay. Okay. While we're waiting for more questions, I think I'd just like to conclude a little bit and leave you with a few key takeaways from this forum. Firstly, HIV prevention and treatment are not just medical issues with an aim to reduce transmission of new HIV infection. They are deeply intertwined with social justice and equity. And I think Sazali showed that, especially with the first initial surveys of acceptance of PrEP and also access to PrEP. Secondly, the well-being of people living with HIV extends far beyond virus suppression. It encompasses holistic physical, mental, and social supports. And I think especially Rina's and Anjana's talk illustrated that quite well. We hope the world hopes to end new HIV infections by 2030. And in order to get there, we need to be able to really look at the 95 care cascades, which is getting 95% of those who are at risk being tested, getting them on treatment, getting them to undetectable viral load, and also providing them with a good quality of life. Women are equally affected by HIV, and their plight should never be taken lightly or forgotten. And any innovation and collaboration is crucial in our fight against the epidemic. So let me just have a quick look again to see if we have another question. So I think
Prof. Saja has raised her hand.
Okay, sorry, I didn't see that.
It's in the participant. I'm not sure if she can unmute herself to ask.
Are we able to do that? We need to ask the admin people because I'm not sure how to do that. Because I can't see it on my screen. Prof. Saja, is it?
Yeah, she said it's
it's okay. All right.
Please ask the question.
Okay, she's going to ask in the chat. Okay. All right. How do patients in public facilities get the integrated services? I presume this is in relation to Rina's and Anjana's services, yeah? So maybe the two of you would like to just chip in a bit?
I guess if they are already UMMC patients and they are already part of the care, then what the integrated services aim to do is, while they are monitored for their HIV-related issues, to also look at other aspects of non-communicable diseases and cancer screening and so on. And so when they reach these thresholds, or essentially if we see signals from their lab values and so on, then they will be referred to the integrated care service. The aim of the integrated care really is to keep our patients engaged in not just HIV care, but non-HIV care as well. And what we have learned previously is that often when we refer them to, say, primary care and so on, they may not actually follow through with their appointments outside of HIV, and often this is largely driven by stigma and discrimination. So we are moving towards a model where we do a little bit of task shifting, particularly with our very able nurses who will be assisting us in doing some of these screenings and follow up. And if they're already part of UMMC patients, they just get referred to the integrated clinic or the wellness clinic.
Anything to add, Anjana?
Yeah, just Prof, on the other hand, if they were getting their HIV care in a primary care facility, like in clinic kesihatan. A lot of the services are actually already provided in clinic kesihatan, like diabetes care and cardiovascular care. HPV testing is also available in some of the clinics. It's just a matter of getting it done in the same clinic setting. The problem is we tend to have this, oh, today is diabetes clinic, tomorrow is HIV clinic, and then making the patients come back again and again. So it's just about finding a way to put it all in like a one-stop center. But the facilities are actually already available in a lot of our clinics.
Yeah. Yeah, I totally agree with that. I mean, I just have to relearn all my diabetic medication. So, so that just shows how long our patients are living nowadays. Okay, so I think we're almost out of time. So thank you once again, Sazali, Anjana, and Rina for sharing your work with us today. Thank you everyone for tuning in to Breakfast at UM. Your presence really means a lot to us, the ID unit, and also to our patients. So let's move forward together in this fight against HIV/AIDS. Happy World AIDS Day. Thank you.
Thank you. Happy World AIDS Day.